Good afternoon, everyone. My name is Ijal Brennan, and I'm the Clinical Coordinator for Falls and Bone Health for Community Healthcare, Cavan, Donegal, Leitrim, Monaghan and Sligo. So I'd like to welcome you all here today to our Exercise and Bone Health webinar. First of all, I'm going to introduce you to Colin McCann. He's the Project Manager of the framework. I'll introduce you to Mary Sweeney. She's a Senior Physiotherapist for the Integrated Falls Prevention Team for Cavan and Monaghan. And I also like to introduce you to Breach Kennedy as well. Okay, so we'd like to say thank you all for attending our webinar today. So as I said, our Exercise and Bone Health Group will present its key findings and recommendations in relation to falls in relation to a strength and balance exercise. Before our webinar begins, I would like to inform you all that the webinar will be recorded and transcribed. So, the cost of falls-related injuries in older people is expected to reach 2,043 million by 2030. The Department of Health showed a 10.5 population increase since 2013, with the largest change seen in the over 65 age group. The number of older adults is expected to almost double in the next 20 years, with the greatest increase in those aged 85 years or over. So in the recent NOCA major trauma audit from 2017 to 2021, falls less than 2 meters were the predominant mechanism of injury for 82% of major trauma presentations in people over the age of 65. And this is compared to 39% in the younger cohort. And 70% of falls occur within the home. So in addition to personal distress, falls and fall-related injuries, there are serious healthcare problems because of association with subsequent mobility, disability, hospitalization, institutionalization, and mortality. So, to put it into a local context, we have 3 major acute hospitals in our area, Letterkenny, Sligo, and Cavan. And the scale of the issue is that there was an average of 3,347 falls-related admissions to acute hospitals per year from 2020 to 2023. This resulted in an average of 36,196 bed days per year, and the average length of stay was greater than 10 days. The above figures, they don't capture those unreported falls, injuries managed at GP or primary care level, attendance at ED that do not require admission. And we all know the impact of falls-related injuries on individuals and their workplace, family life, care requirements. This isn't captured in this data either. So we're heading for a falls-related crisis in our health system, if we're not there already. We all know many falls can be prevented. So falls and injury prevention needs multidisciplinary management. So this is why we have decided here to develop a falls prevention framework. So the purpose of this framework is to support the implementation of an integrated multi-agency, multidisciplinary, lifelong approach to preventing harm from falls, with the aim to reduce the number of falls causing harm to the population of community healthcare, Cavan, Donegal, Leitrim, Monaghan and Sligo, as a consequence of age or disability. So addressing this serious public health issue requires a cross-sectional, collaborative, whole system approach to promote healthy aging, preventing falls, managing falls, and supporting people at risk post-fall. The biggest opportunities for promoting healthy aging and preventing harm from falls are in community dwelling older persons, where the main cost drivers, are ED admissions, hospital admissions, and continuing care. The aim of this framework is to provide guidance for local areas on implementation of such an evidence-informed approach. So by the end of 2024, we hope to have a framework that will support all care groups. The framework will contain recommendations in relation to medication review, residential settings, incontinence, technology, environmental issues, and exercise and bone health. And the framework will be informed by national and international best practice, including the World Fall Guidelines, September 22, and the Australian Fall Guidelines. So the framework is going to provide the basis for falls prevention implementation plan. So this is our progress to date. Each working group has not only had to assemble evidence for their particular area, but I've also had to understand and synthesize it and convert it into practical advice in the formation of key findings and recommendations for the development of the framework. So we're now currently in the period of review, and with your help, we're going to get the feedback, on all the work to date. And the plan is to have the framework published by the last quarter this year. So we're hoping this falls prevention framework will have the potential to contribute to service development, improve quality of care, promote education on falls, as I previously said, support clinicians in their clinical practice, and will hopefully stimulate the development of falls prevention services to help people keep doing the things that they enjoy doing and doing well by minimising their falls risks. So the purpose of the webinar is to seek, as I said, your feedback as experts in the field to ensure that this framework is a document that can be of benefit to all. So please note, this document is aimed at adult age 50 years and older, as majority of existing research relates to older adults. Expert opinion would indicate that much of this work is also applicable to people with intellectual and physical disabilities and complex, enduring mental health issues. So, without further ado, I'm going to pass you on now to Mary Sweeney. Mary is, as I said, a senior physiotherapist with the Integrated Falls Prevention Team in Cavan and Monaghan, and she's going to go through the work of her working group. Thank you.
Thank you, Adele. I'm just going to share the document.
Thanks, Adele. Just while we're waiting for Mary to get her presentation up, Breeze Kennedy, maybe you'd introduce yourself, please, just as a panelist member.
Thanks, Colin. My name's Breeze Kennedy.
No, mute, Breeze, sorry, or else we're having a technical issue.
Can you hear me now?
No, we continue to have a technical issue. Okay. Well, Breeze is a program manager in health promotion and with a specific interest in a range of topics, but falls will be one of her passions. So we're delighted to have her here. She's also a member of the working group that Mary Sweeney is representing here with the work. So thanks, Breeze.
Thanks,
Mary,
Colin.
over to you.
And I do see some of the people on the webinar can hear me, so thanks for that. So I work as chronic disease lead within health and wellbeing, and as Colin has said, have been working with Mary in the development of this part of the framework. Thanks.
Thanks, Colin, Adele and Breed for that. Colin, can I just check that everyone can see what I've shared? Can you see what I've shared there? Yeah, Breed is. Yes, thanks everybody. So as Breed mentioned, myself and Breed are on this group along with Eileen.
Excuse me, Mary, can I just stop you for a moment because I can't actually hear you. Can I ask people in the chat, can they hear what Mary's saying? Because it's not really important that I hear it, it's important that people in the chat. Agnes says yes, Brita says yes, Louise says yes. Okay, so John, everybody says yes. That's great. Unfortunately, I can't, but don't worry. You're in good hands. Thanks, Mary. Bye-bye. Okay,
thanks, Colin. I hope we get those issues sorted on your end. As I mentioned there, myself and Breed are on the group together, along with Irene McPartland, the CNS from Sligo Leitrim, and Donna McGroarty, who's network manager in Monaghan, and Aidy McEnany, who's the dietitian for the ICTOP team in Cavan Monaghan. So we've a wide variety of expertise on the group. We started this journey, as Adele mentioned, almost 2 years ago, and I suppose we've had a lot of information to get through over the year and trying to bring it to a point now that we'll be able to get feedback from yourselves today on what we have, the information we've accumulated, and then trying to bring it to the point of for a quarter, the last quarter of the year, for it to be distributed amongst everybody. So we welcome your feedback, and as Colin mentioned, just to put any questions through the chat. So this is done in a Word document, as this is how we delivered it or put it together ourselves. And I'll run through it with you today, and obviously you will have it there hopefully to look through after the webinar in greater detail, and come to us with any feedback you feel would be necessary. So I'm just going to start with the introduction, and as we mentioned there, and Edel went through the amount of falls that do occur. So 34% of older adults considered at low risk of falls will experience fall in the following 12 months, and 22% of those who fall will sustain an injury. And I suppose that's what we would see in clinical practice. Falls are preventable through a proactive approach to healthy aging with an emphasis on physical activity, exercise, strength and flexibility. And that was the World Health Organization in 2023. It is important to note that managing many risk factors for falls like gait and balance has wider benefits beyond falls prevention, such as improved intrinsic capacities, as in physical and mental health, functioning and quality of life. So maintaining that independence. It's also important to include that the World Fall Guidelines in 2022 recommended screening for malnutrition, for obesity, for sarcopenia, including sarcopenic obesity, for vitamin deficiencies like vitamin D, B12 and folic acid, and for substance abuse as well to moderate alcohol use. Just bring this down a wee bit. From the affinity that would have been done prior to the most recent guidelines, strength exercise and adequate protein are also effective in the intervention for preventing falls. So I'm just going to move on to the algorithm that was developed by the World Fall Guidelines in 2022. And this is widely available, and we did use this as a starting point for the identification of falls. So primarily we need to identify those at risk or that have had a fall to implement some of the guidance documents that will follow. So they would suggest, and I'll show you the algorithm in a moment, but they would suggest that you would ask if a person has had a fall in the past year. And 3 questions that have also been suggested is that you would sensitize this by asking the person if they feel unsteady when they're standing or walking, or do they worry about falling, as well as have they fallen in the last year. And that is more likely to get this group and cohort of people identified early. And if a patient answers yes to any one of these questions, you refer on for assessment for their falls risk. So that was just that piece there. And those at low risk of fall will benefit from a community exercise and home exercise program. And that from the World Fall Guidelines. And level 1A is the highest level of research behind it. So there's strong evidence to support that in that document. So those with an increased risk of falls, more than one fall in a year, would benefit from individualized program with the physiotherapist, plus or minus a trained instructor. An example of this would be the FAME or the Otago program that you may already be familiar with, that has been run out across the region in the past and is currently ongoing. And those with a high risk of falls would benefit from a multifactorial falls risk assessment. So just bringing that holistic approach to a falls assessment for those at higher risk. So the algorithm that was originally developed by the World Fall Guidelines, we adapted it slightly. So you can see on the top, on the blue boxes there, that an opportunistic case finding, which would be asking those 3 key, or one of those 3 key questions, which is have they had a fall in the last year, and identifying those. And those who have had a fall in the last year, you're asking them, do they feel unsteady or do they worry about falling? Now, additional to this, we identified that those who are osteoporotic often are missed. And we've added in a piece there to the large blue box on one side. You see patients who are diagnosed with osteopenia or are high-risk patients, those who are oncology patients or on high-dose steroids or recent low trauma fractures, that we should be also asking those if they've had a fall in the last month, so that we are bringing those osteoporotic or potentially osteoporotic patients into the falls pathway. And then when we have identified whether they've had a fall or not, or they worry about falling, then we're trying to identify whether they're low risk, intermediate risk, or high risk. So how we identify that is they're low risk if they have had, if their gait speed is more than 0.8 meters per second, or their timed up and go is less than 15 seconds. So that differentiates between our low and our intermediate risk. For those that are at high risk, they are coming into the high, so you can see the two red boxes on the right hand side of the page there. So we assess them for their level of, they assess their fall severity. So when they've had a fall, if they've had an injury, or they've had more falls in the last, more than 2 falls in the last year, their frailty level, so that has been identified as a clinical frailty scale of 4 or more, and that they were on the floor or unable to get up after the fall, or they had lost consciousness, or they were suspected syncopal event. So that puts them into the high risk, and the recommendation that all those at high risk would have a multifactorial falls risk assessment. We would also have adapted the algorithm to include that those at intermediate risk would also have a multifactorial risk assessment done, and that the multifactorial risk assessment would be a balance gait and strength assessment done by a physiotherapist, and then onward consideration to the FAME or Otago programs, education on falls, individualised MDT assessment, and onward referral as appropriate, one-to-one intervention as required, or group-based intervention depending on what was found on their physiotherapy assessment, and optional onward referral to exercise professionals if that's available. And the low-risk group, we would suggest that they would be get education on falls, prevention, bone health, diet, physical activity, and environmental factors within their home, and linked with other external organisations and classes that may be available to them. And the recommendation overall from the guidelines would be that those at low and intermediate risk would be reassessed in 1 year, and those at high risk would be reassessed at 30 to 90 days to try to monitor and manage those risk factors. So that's the starting point of our work. And then we broke up into our sections into bone health, strength, and balance and exercise. So I'm going to go through each of those individually with you now in a table format. So just starting with bone health. So osteoporosis is present when BMD is 2.5 standard deviations or below the average value for a young healthy woman with a T-score of less than -2.5. And then osteopenia is -1 to -2.5, and that's a WHO definition. So just to go through this, we've broken it up into dietary initially. So you'll see on the each side there, it's bone health and it's the dietary, and then the guidance we've put in the middle, and then the research to support this data is in that green section there. So initially, eating a healthy balanced diet ensures that all nutrients necessary for bone health are provided from food. A healthy balanced diet can be achieved by following the principles of the food pyramid. It is recommended that older adults should have 3 to 4 servings from milk, yogurt, and cheese shelf per day. And the resources of healthy eating for older adults, Healthy Ireland 2023, and the Food and Nutrition Hydration Policy for Adults Accessing Disability in the HSE 2022 are resources for that. Calcium and vitamin D improves bone mass among people with low bone density, and it reduces the risk of osteoporosis and falling. Moving on then to calcium. The average older adult aged 50 years and over needs 1,000 to 1,200 milligrams of calcium per day. See resource there that the calcium-rich food chooser from the Royal Osteoporosis Society will give guidance on the calcium content of each food. And improving calcium intake by using dairy foods is a readily accessible intervention and has been found to reduce the risk of falls and fractures commonly occurring in aged care residents. And there's the research to support that. Vitamin D then, adults aged 65 years and over should take 15 micrograms or 600 IU units supplement every day all year round. Adults under the age of 65 should take the same dosage from Halloween to St. Patrick's Day or all year round if they have a darker skin tone or reduced sun exposure. And there are 3 ways to take vitamin D supplementation: as a multivitamin supplement that contains the 15 micrograms of vitamin D, as a calcium and vitamin D supplement, and as a vitamin D supplement that contains 15 milligrams of vitamin D on its own. So that's there from 2024. And if a person has already been advised to take vitamin D supplementation greater than 15 micrograms by a doctor or a nurse, they should continue to take this. Consider using a weekly dose preparation of vitamin D for older people with cognitive impairment who have problems with medication adherence, and avoid high doses of or once yearly mega doses of vitamin D, as such doses can increase the risk of falls. And there may be contraindications for vitamin D supplementation in hypercalcemia, and these would need to seek advice. And that was taken from the Australian guidelines 2024, which will be published shortly. Malnutrition. Older adults who are at risk of malnutrition or being malnourished may have a higher chance of suffering from bone loss and bone fractures. Nutrition screen must be completed using a validated screening tool such as the MUST scoring tool on those who are at risk of falls. And alcohol use of excessive alcohol has been shown to be a risk factor for falls and osteoporosis. And there's no safe limit for alcohol. Less is best. Limit alcohol intake and don't exceed the weekly limits of alcohol, which are 17 units for men and 11 units for women. And that's from the Healthy Eating for Older Adults guidelines in 2023. So just touching on the exercise for bone health. So exercise itself reduces falls-related fractures by 27%, and that was by Sherrington in 2019. And the Royal Osteoporosis Society have done a nice infographic called Strong, Steady and Straight. And Strong recommends that the 50 minutes of moderate impact exercise and 20 minutes for the frail older adult with lower impact exercises. Muscle strengthening 2 to 3 times per week, which must be progressive and include some back strengthening exercises. Steady, and that references to the balance, so that balance exercise should also be challenging and should be completed 2 to 3 times per week. And straight is in reference to the back, so that the correct lifting and handling techniques should be used, and that we should be strengthening the back muscles for that. And the Canadian guidelines on osteoporosis in 2024 would support this with balanced muscle strengthening, general physical activity, and then those spine safe movements. And at the bottom, you'll just see reference to all the guidelines we mentioned there. And you can see the nice infographic there that was done by the Royal Osteoporosis Society. So that completes the information we had done on bone health. And I'm going to just move on to the next section, which is on strength. So when we talk about strength, we mention sarcopenia, and I'll just define that for you as an age-related loss of muscle function is known as sarcopenia. Its definition includes loss of muscle strength and power, as well as reduced function. It occurs with increasing age and is a major component to the development of frailty. So there is a change in muscle fibers and motor unit size with aging, likely that it causes the slower twitch characteristics in the muscles. What happens is your slow twitch muscle fibers tend to get bigger, fast twitch gets slower, or there's less of them. So with the increasing age, we lose muscle mass. So lean muscle mass contributes to 50% of total body weight in younger adults, but this decreases to about 25% in those 70 to 80 years old. So just to start again on the layout that we used before, we'll go through the dietary importance of diet in muscle. So starting there with eating a healthy, balanced diet ensures that the nutrients are there for falls prevention. And a healthy, balanced diet can be achieved by using the principles of the food pyramid. It is recommended that older adults should have 2 to 3 servings per day of high quality protein foods from meat, poultry, fish, eggs, beans, and nuts. And as we mentioned before, those references to the hydration and that we mentioned earlier on. Protein is recommended to eat a protein-rich foods throughout the day and to have a protein source at each meal and snack. I think that's very important to try to encourage the protein at each meal and snack. Older adults should be encouraged to have 20 to 30 grams of high quality protein at each meal for optimum muscle protein synthesis. And a resource that is recommended there is protein, why it is important and where to find it. And that's a resource that goes through the amount of protein in various foods and is a good reference point. And for those that may have severe kidney disease, protein can be a challenge, so they may need to have an individualized dietetic assessment, or if they're on dialysis, it'll need special consideration on what's the best guidance for those. Malnutrition. So being at risk of malnutrition or being malnourished may increase the risk of falls, and nutritional screening should be completed again using the MUST screening tool again, and that's from the falls guidelines also. And the body mass index, so being underweight or having obesity may be associated with a higher risk of falls, whereas normal or overweight individuals have the lowest falls risk. BMI values between 24.5 and 30 were associated with the lowest risk of falls. Vitamin D, as we mentioned before, is also important here, and to reduce the risk of falls associated with muscle weakness, and as we mentioned, the vitamin D. So from an exercise point of view, exercise for muscle strength should be 2 times per week, moderate intensity with your major muscle groups, and that was from the World Health Organization in 2020. Strength should be assessed using your sit to stand and your grip strength, so getting lower limb and upper limb assessment done there, and individualized progressive programs, so that these strengthening programs would be progressive and they have to have some level of resistance that we can progress with, and Tai Chi can be included, and that was from the World Fall Guidelines again. And from the 2022, the World Health Organization recommends 3 times strength training per week. So as we mentioned there, those resources are available, and we've mentioned there, and that's the infographic by the 2023 by the World Health Organization, and you can see the muscle strengthening there in that central section. So the last piece I'll just move on to was our exercise and balance section. So we've combined both these, and I'll just run through that with you. So the WHO defines physical activity as any bodily movement produced by the skeletal muscle that requires energy expenditure. Physical activity refers to all movements, including those during leisure time for transport to get to and from places as part of a person's work. Both moderate and vigorous intensity physical activities improve health. And balance is defined as an individual's ability to control their centre of gravity within the limit of their base of support. Aging, neurovascular problems, weak muscle strength, limited range of motion and cognitive decline could adversely affect the static and dynamic balance controllability, which increases the risk of falling and negatively affects the performance of activities of daily living. So again, just going through in the same format, we mentioned the protein there from a dietary point of view, and protein intake should be encouraged soon after exercise to aid muscle synthesis. Older adults should consider exercising before consuming a meal containing high quality protein, or having a protein containing snack or drink after exercise. Older adults should consider consuming 20 grams of protein after exercise sessions. And as we mentioned, the Protein Y resource there. And there's mention to a ProteAge study as a reference there. So just moving on to hydration. Good hydration helps to prevent dizziness and confusion, which can lead to falls. Women should aim to drink 6 to 8 glasses of fluid and men 8 to 10 per day. There may be contraindications for fluid intake in conditions such as heart failure or renal failure, and in these specific conditions, further advice would need to be sought. From an exercise point of view, the HSE this year published the HSE sedentary behaviour guidelines, and that's to diminish the benefits of exercise diminishes with time if exercise is not continued. 20 to 60% of older adults worldwide meet the WHO activity and sedentary behaviour guidelines. So that's still a large amount of people that aren't meeting that guidelines. However, around a quarter of all adults, over 40% of people aged 70 years do not meet the physical activities to maintain and improve their physical and mental health. And Tai Chi may reduce falls in that case. So the WHO recommends 150 to 300 minutes of moderate intensity or 75 to 150 minutes of vigorous intensity. Exercise reduces the rate of falls between 23% and reduces the number of people who fall by 15%. And multiple types of exercise, balance, function and resistance exercises helps reduce the rate of falls by 35% and reduce the number of those falling by 22% in the Cochrane review. The benefits, as I mentioned, reduce once it has stopped, and exercise based on dance and walking alone have had uncertain effects. Exercises should be challenging, they should be safe, and they should be achievable. And just recommendations there. If an individualized tailored exercise program is deemed necessary, a referral should be made to physiotherapy for assessment and prescription of same. Ensure that physiotherapy contributes to the design of community exercise programs aimed to prevent falls, and the need to have community exercise programs available post-discharge from clinically led exercise programs, and those community programs, as I mentioned before, the FAME and the Otago, if they need that to maintain that. So if we have community-based programs, which include balance, function and resistance exercises as a safe exit strategy from the clinical setting, it is most effective, and that's seen in the Australian Fall Guidelines. So the National Physical Activity Guidelines suggest that move your body and be active in a way that you enjoy. Any physical activity is good physical activity. and every move counts. Breaking up and replacing some of your time spent sitting with some movement can benefit your health. And they talk about exercise snacking there, so just to promote those small snippets of exercise. Being physically active can help you keep your independence into older adulthood and try to limit the amount of time you spend sitting still. And from a balance point of view, the World Fall Guidelines mention trying to keep your balance work as functional as possible. So trying to use the sit to stand or step ups and progress these as able. The program should last 12 weeks to make the difference, and more likely for the person to maintain those gains. It must be progressive and it must be individualized, and balance assessments should be completed before and after the program using validated outcome measurements such as the Berg, Tinetti, mini best tests and gait speed, as mentioned in earlier on, should be assessed also. And as we mentioned, the balance exercise, WHO also support this by saying it should be done 3 times a week, and balance and functional exercises reduce the rate of falls by 24%. So good practice points also when you're doing balance programs would be to do some reactive balance training, which that would include stepping and reaction stepping to encourage a reaction to any loss of balance. And focus falls prevention exercise, maintaining balance during functional activities, and as mentioned, the sit stands, the squat, the reaching up, reaching down, and that's in the Australian World Falls Guidelines as well. They're just some resources, and as we mentioned, the physical activity, the WHO and the HSE physical activity and sedentary behaviour infographic that's there at the bottom. So that concludes the information that we have brought together from a dietary and physical activity. Is quite a broad topic, so we did our best to bring it together with the most recent research from the available guidelines. So I'll stop sharing that now.
That's great. Thanks, Mary. That's really good. Really comprehensive review of all the findings and recommendations for exercise and bone health. It's a massive area, but we all know that exercise plays one of the most important roles in fall prevention, and we talk about that it's not just balance and strength, it's about the functional component needs to be challenging and progressive. And when you're running a bone health, your calcium and vitamin D, so really good. There's so much there, and so thank you so much, Karen. So if anyone has any questions, you can just type it in the chat, and Colin and I will be able to kind of direct questions to Mary and Breed, and even after then we can email and the answers to you. So whatever is easiest. But yeah, so if you have any questions, then you can just type it in the chat. But again, thanks very much for Breed and you're part of that exercise more than working group. So there's a lot of work done there over the 2 years. Really nice way you're demonstrating, the different pathways for those who are different levels for fall. So thank you guys.
Thanks, Dan.
Now we have just one comment so far from Aileen Heatherton. Aileen says, thank you. It was a very informative presentation. Agnes McManus has followed that up with thank you, Mary. Great presentation. Very valuable information. So there you go. Well done.
Thank you all.
If anybody else has any comments or questions, please put them in the chat. There's a lot of positive stuff coming. I take it you're watching the well done to all involved. There's thank yous, there's congratulations, so great stuff.
Yeah, so it's a huge area, and you really know it every aspect. So thanks very much.
Yeah, well, they're coming through thick and fast now. Mainly comments and saying that it's nice to see the under 65s have been included there. So yeah, being one of those people myself, under 65, I'm grateful to you. I learned a lot today, Mary. Maria Armstrong's just asked a really good question, and it's about where do we go from here now that we've done all this work? And I think that the challenge is to get a framework developed, Mary, that actually reflects all this good work and is easy to read and that will be accessible and usable. And then we'll try and get an implementation plan together that will actually implement the framework. So that's the approach that we're going to take. There is an actual question here as well from Caroline Wheeler. Hello, Caroline. Does the document need to include the increased risk to bone density from smoking and prescribed medications such as antipsychotics, PPIs, and anticonvulsants? Also, the increased risk post-menopause. Mary or Bruce Kennedy, do you want to tackle that? I think it's probably more a question for our medication review panel as opposed to this particular panel. But anyway, bone density is one of our topics. So, Mary.
Yeah, I suppose we did focus on, you know, the osteoporosis or the bone health piece with patients that are coming through the DEXA scan with a result of that. But there are also a lot of patients out there that are at higher risk from, as they mentioned, the smoking, postmenopausal clients as well. So, I mean, I suppose it's that. What we're doing is trying to ask the question about whether they're at risk of a fall or whether they have fallen. And I suppose that's where we're linking in the bone health to the falls. But we can consider including some reference to the higher risk aspects of bone health, such as smoking and those PPIs. We may have to link in with the pharmacy group a little bit around that as well.
Thanks, Mary. John's now motivated to deliver exercise snacks, so that's good. I think I was exercise snacking during your presentation, Mary, I must say.
Well done.
We have a query from Jocelyn, or Jocelyn, I'm not sure how to pronounce that. Can you please elaborate why elderly with darker skin tone need to take calcium from Halloween to St. Pat's period? Anybody? I know it's the 2024 Irish guidelines, but does anybody know the rationale behind it?
I think I mean, obviously Aidan, our dietitian, is the expert in this area, but I'm assuming that the sun intensity in Ireland and the colour of the skin is impacting on the vitamin D production there, but I could be corrected on that. But as I say, we can get back to with a very specific but that would be my understanding there.
Okay, yeah, something we can address after the webinar. Thank you. That seems to be the last question. If there's any more questions, folks, now's your time to get them up. Otherwise, we'll draw a line under the webinar. I'd like to thank Mary again and Breeze and all the working group for the tremendous work in this area. And I look forward to Adele and myself are going to be the ones that have to try and put it into some sort of framework. So we're looking forward to taking all your work and trying to make it I suppose easily digestible and service user friendly as well. So thank you.
Yeah, that's great.
There's no more questions coming through, folks. So we'll just thank you all for attending, and we will draw a line under the webinar. Thank you very much indeed to the speakers and to everybody who attended. Thank you. Okay. Bye bye.
Thanks again, Colin. Thank you very much, everyone.